Thank you very much for Mr. Rajput for inviting us to such a wonderful function, such a wonderful conclave on innovations in cardiology. And the innovation that you talked about, finding drugs and ideas to improve the compliance of patients so as to reduce the cardiovascular risk in our patients. We know that the cardiovascular diseases are growing epidemic proportions, not only in world but also in the low socioeconomic countries and the developing countries like India as well. And we know what are the risk factors. We know what are the solutions to these risk factors as the developed countries have shown us that by controlling these factors, we can reduce the burden of cardiovascular disease. But the challenge is how to implement the control of these risk factors. I'm sure these ideas are going to do that. To chair this session on this cardiovascular risk management, we have chairperson, eminent Professor S. C. Manchanda with us, who is Senior Consultant, Department of Cardiology at Gangaram Hospital. He was formerly Professor and Head of Department of Cardiology at All India Institute of Medical Sciences, New Delhi. With his clinical, teaching and professional experience of 45 years, he has over 400 scientific papers in various national and international medical journals, including 50 chapters in standard medical books. He has been honored with many national and international awards, including Padam Shri by the President of India. He has done original work in the field of high altitude problems and lifestyle modification, including yoga and meditation. Editor-in-Chief of Journal of Preventive Cardiology and Chairman of World Academy of Spiritual Sciences. With this background, he is the right person to chair us and guide us that how besides lifestyle, the pharmacy can be helpful in controlling the risk factors, whether it is required at all or not. The speaker for this session is Dr. Praveen Chandra. He is a leading Indian cardiologist and chairman of Interventional Cardiology and Medanta, the Medicity, Gurgaon, India. He is recognized as one of the leaders in angioplasty in the country and is proficient in a lot of new devices and technologies. He has also served previously as Director of Cath Lab and Acute MI Services at Max Healthcare and Consultant Cardiologist at Scott's Heart Institute. He is Fellow of the Endovascular Intervention Society of India and the Asia Pacific Society of Interventional Cardiology. Dr. Chandra has been a distinguished faculty member in various international meetings and was the organizer and director of AMI course held in New Delhi in the years 2005 and 6. He has published approximately 100 articles, reviews, and abstracts in various national and international scientific journals. With this, may I request Dr. Chandra to please give his talk. No, before Dr. Chandra gives his talk, I'll request Dr. Manchanda to give a brief introduction to the subject and carry the meeting forward, as I may have to leave in between. Dr.
Thank you, Dr. Harshvardhan. As you heard, this is a very important topic which has been chosen for this session because cardiovascular disease is the leading killer of mankind throughout the world. Its incidence is increasing, especially in the developing countries. A lot of research has been done to find out why this disease occurs. We know most of the risk factors, and we know that if we correct these risk factors, the disease can come down. However, there is a lot of gap between the knowledge and its application. What is happening is that the disease is still progressing very rapidly. Actually, it has assumed epidemic proportion in most of the middle income and low income countries like India and China, which are progressing rapidly economically, but they are losing a large number of lives and a lot of disabilities occurring. Why is it that the knowledge is not being applied? Obviously, there must be several reasons. We try to change the lifestyle of the people, and they are not easy to change. We try to give them drugs, they don't want to take it. So there is something happening which is not really suiting the public. And therefore, I think a poly pill, which has been researched in this country, developed in this country, I think will be a big boon. And we have seen the compliance of single dose is much better. It is cost effective also. This may be one of the methods of decreasing the burden of cardiovascular disease. Without taking much time, because we are already behind time, it's my pleasure to invite Dr. Praveen Chandra, who is one of the top interventionists of this country, as well as an excellent holistic cardiologist, to address this subject, how to reduce the cardiovascular risk. Dr. Praveen Chandra, please.
So, good evening to all of you, and I must thank Professor Manchanda and Dr. Harshvardhan for the introduction. And I now thank the IAMICON 2014 for this opportunity, and thank Mr. Modi and his entire group, including Rajput, for this wonderful evening and sharing of our ideas. So now let me take you to this presentation, and this is basically again an innovation, a very, very simple innovation which has been now put forward, although it has nothing to do with interventional cardiology where I am involved 90% of the times. But let me tell you, rest 90% when we start spending with the patient, this is where what is required. And this innovation I'm going to discuss with you, and because it is very, very important, and really it can change the life of the society and the age of the society. So cardiovascular risk management is a very, very challenging situation still, and we are still looking at solutions. And this is going to be one of the important solutions. So why we are so much interested in all this? Because as you can see here, the biggest cause of death in India also is cardiovascular diseases. Still, many people are dying because of this. And as you can see it, as it compares with cancer, many other diseases, cardiovascular diseases are foremost. So the biggest challenge is to prevent it. Because we have learned how to treat it. We know now many ways of bypass surgery, angioplasty, pacemaker, and many things. But still, many people are dying. So to prevent that, many studies were done to assess what is the risk. How does it happen? And this is one of the latest studies, the InterHeart study, which actually identified several risk factors. And it showed that as risk factors accumulate, as many risk factors are there, the chance of dying increases. That has been identified. Now the next challenge is, how do we prevent it? And the very, very provocative question is, can we prevent a heart attack? Can we prevent stroke? And can we prevent peripheral vascular disease? Because most of the times, patients come to us 90% of the times when they already have a heart attack. Now, the challenge is how to prevent it before it happens. And the answer to this question is, yes, we can do it. And we know how to do it, but we don't really are able to do that because of various limitations. This is in general population, but in those patients who already have a heart attack, now the challenge is how to prevent the second heart attack, how to prevent a repeat stroke, how to prevent progressive peripheral vascular disease, which we commonly call as secondary prevention. And the answer again is, yes, we can do it, and we can also prevent deaths by just doing simple methodologies of treatment. No expensive treatment is required for this. And let me take you through this presentation. These are the various studies which were done using statins and controlling cholesterol. And as you can see here, both for primary and secondary situations, it was found to be effective in reducing the incidence of disease and also preventing death. And this, as you can see here, as you decrease the level of cholesterol, the CHD events decrease. So this has been proven in so many studies, and as you decrease the level of cholesterol, the incidence decreases. Similarly with hypertension, hypertension is also a bad disease, a silent killer. And this is also the single largest contributor to death. And let me tell you, we pay the least attention to hypertension. Because if you look at this data, the slide is missing here, but the data shows that the minimum treatment, the minimum number of people who really get treated out of 100 is only 30. So 30%, 1/3 of the population who have hypertension is really getting proper treatment. 1/3 are getting treatment, but they are not getting their blood pressure controlled, so the effect is not there. And rest 1/3 actually do not get the treatment. So you can understand the biggest killer is still remaining untreated. And all this high cholesterol, hypertension, why it is happening, the challenging situation is there in front of us, because in India also, rapid urbanization, stress, less physical activity, and all those conventional risk factors of changing dietary patterns, leading to increasing number of cardiovascular diseases and leading to early onset of disease, which is very, very particular to our Indian patients. Today only I treated at least 3 patients who were 37 years of age. So very, very fierce disease and almost going to the deathbed. So basically this situation has to be controlled, and that control can only happen when we try and start treating them early and completely. So this changing epidemiology, we have to use our existing knowledge, and the solutions can come from what we have gained up till now in implementation of guidelines. And one of the concepts which Dr. Manchanda introduced is the polypill concept, because we have to devise a simple strategy. We cannot have a complex solution to a simple problem. So we have to have a simple solution to a complex problem. So early detection of risk factors for cardiovascular disease is the key. And the interesting thing is that all these risk factors actually stay together. They are friends, and it is easy to treat all of them together. And this is how the concept is. And the cardiometabolic syndrome, which is a congregation of these factors leading to early onset of disease, as you can see here, starts very early, between 20 to 40 years, and it increases as the age advances. And the important of them is, again, hyperglycemia, hypertriglyceridemia, low HDL, and abdominal obesity in our Indian patients. So we have to identify these factors by calculating body mass index, blood pressure screening, cholesterol examination in people who are not having disease. We have to identify these people from the society and advise them lifestyle management strategies, which is the foremost before starting any treatment. Now, controlling risk factors, what happens is, if you look at the data, the control of blood pressure, in spite of regular visit to a doctor, is less than 40% or less than 50%. So which means we are very ineffective in treating a disease which is killing people by heart attacks, strokes, and peripheral vascular disease. Look at this, just shows that only 30% of our patients, despite getting drugs, are getting controlled for hypertension. So we have to start looking at various aspects, how we can do that. And one of the guidelines for actually cholesterol control came from the ACCHA, which has simplified things, but still we have to look as to how we can implement this. And this shows that people who have LDL cholesterol of more than 190, even if they do not have any disease, they need treatment. But those people who have LDL cholesterol between 70 to 190, if they have risk factors, they also need treatment. So how do we identify these people and start giving treatment to them, which is sustainable for a long period of time, because it has to be lifelong. So those strategies have to be found out, and these are simple risk calculators which are now available for these people to be identified whether they need any statin treatment or drug treatment or not. As far as aspirin is concerned for primary prevention of cardiovascular events, in diabetics it has been recommended in this guideline that aspirin should be given to people between 45 to 79 years of age in men and 55 to 79 years in the dose of 75 to 160 milligrams as a primary preventive strategy in diabetic individuals. For prevention of stroke, again, for patients who are unable to take oral anticoagulants, aspirin should be given up to a dose of 325 milligrams. So aspirin is a good primary preventive strategy in patients with diabetes and previous stroke. It has to be given to prevent the next event. Then in acute coronary syndrome, how do we prevent next event or morbidity or further mortality? By giving antihypertensive agents, giving antiplatelets, and by giving statins. So whatever we have done angioplasty or bypass surgery or any procedure, it has to be followed by a preventive strategy. And that, as you can see here, 3 drugs have to be given to these patients. In patients with hypertension, the concept of polypill has been now very well established, and it, as you can see here, from the 2013 ESC/ESH guidelines for management of arterial hypertension, polypill, that is a fixed dose combination of several antihypertensive drugs with a statin and a low dose aspirin, with the rationale that hypertensive patients often present with dyslipidemia and not infrequently have a high CV risk. These patients can be given polypills to control their hypertension and dyslipidemia together. Then European guidelines for CVD prevention 2012 again shows that individuals without disease, a polycap formula could conveniently reduce multiple risk factors at the same time. So simplify the treatment for those who do not have disease, because they will not take medicines if you write 4 medicines to a person who is totally normal and is walking around in the society. So compliance is a big issue in these people. They will not take 4 drugs at the same time. And if you look at this, what happens in this premier study, in the secondary prevention study, it showed that continuation of taking all 3 medicines is just 66% at 3 months, and discontinuation happens very, very rapidly. So we have to find a solution, and we have found a solution. Cadla has found a solution for that. Looking at this pure study also, that a very small number of patients actually will take so many drugs. ACE inhibitors, statins, beta blockers, antiplatelets, all these drugs have to be given, but patients do not take it, all of them. So all this data is just indicating that we have to have a compliance strategy, because we have to prevent the second event or the first event in patients who do not have disease. So a fixed dose combination on adherence and risk factors was studied, and in these trials it showed that if you give a fixed dose combination, the compliance is far better. 77% versus 23% in usual care. And looking at this data, if you look at this, all those patients who take all the drugs, they are better off than those patients who have discontinued medications. So lesser the number of drugs, the more the incidence of events, or lesser the incidence of survival over a period of time. So we have to ensure that they take all these medications for a long period of time. So reducing dosage demands is the most effective single approach towards enhancing adherence, because we can diagnose disease as good physicians, we can prescribe medicines as good physicians, but if the patient doesn't take medicines, everything is a waste. So fixed dose combination therapy like polycap reduces dosage demands and compliance improvement. And so this drug, which is the polycap, innovative idea to decrease CVD risk with improved compliance. So what it has is salicylic acid, which is aspirin, ramipril, simvastatin, atenolol, and hydrochlorothiazide, this combination. And it has been shown that the bioavailability of these drugs is maintained, and 92% patients who were put in the trial actually completed the trial, and the polycap actually preserved the individual pharmacokinetic profile of individual drugs in this study. And this study, which is the TIPS study, which was published in Lancet, shows that there was adequate BP lowering with polycap when it was compared with 3, 2, and 1 drug therapy, and the reduction in heart rate, LDL levels, platelet aggregation, everything happened to a satisfactory level. And the advantage of this polypill containing all CV preventive medicines led to significant CV risk reduction, improved adherence and compliance, reduced side effects, and cost savings. It is so inexpensive to just take 1 tablet. So it has a great implication on widespread usage of this drug for preventive strategies on a long-term basis, which will affect both physicians, patients, and policymakers. So who can benefit from polycap? Basically, patients with established disease like heart disease or stroke, with or without hypertension, or with or without dyslipidemia, and patients without cardiovascular disease but who have hypertension and dyslipidemia. So these are the 2 groups who can be given this medicine, and thus large number of these patients can continue taking medicines, leading to reduction in CHD and stroke, which are the biggest killers, control of hypertension and dyslipidemia, risk factor reduction, and basically new guidelines recommend polypill for effective control of multiple risk factors. And this is an effective and well-tolerated solution which has been studied now for changing the epidemiology of this disease. So with this, I think I will stop here, and thank you very much for your kind attention.